welcome to the Journal of the American Society of Echocardiography podcast. It is my pleasure to present the weekly Summer 2021 series. My name is Dr. Johri, and it's also my pleasure to have two guests today. Today we'll be talking about the paper entitled Risk for Increased Mean Diastolic Gradient After Transcatheter Edge-to-Edge Mitral Valve Repair, a Quantitative Three-Dimensional TEE Analysis by Dr. Oguz and his colleagues. So before we go into the paper, I wanted to introduce my esteemed guests. So firstly, we have Dr. Dan Belliveau. Hi, Dan. How are you doing today?
Great. Thanks for having me.
Okay, great. Dan, can you introduce yourself to the audience a little bit? Tell us about yourself.
Okay. Not much to say, but Dan Belliveau, I'm the Echo Fellow here at Kingston General at Queen's University. I work with Dr. Johri.
That's great. And how have you found your training under us?
It's been fantastic. I think I have to say, but
that's the right answer.
Yeah.
Good. And Dr. Bisleri, who's also a colleague of mine and is associate professor at University of Toronto. It's a pleasure to have you. I know you were busy in the OR today, and you're just between patients, and we're delighted that you have been able to hop on this podcast. So please introduce yourself.
Thanks, Summer. Yeah, my name is Gianluigi Bisleri. I'm a cardiac surgeon originally from Italy, and then I actually spent a few years with Dr. Johri and the team at Kingston and Queen's University. I recently moved to St. Michael's Hospital and University of Toronto. I'm very glad to be here today, especially since one of my main areas of focus is less invasive treatment of mitral disease, both surgically, so with minimal invasive mitral valve surgery, but also transcatheter approaches. So I found this, chance to discuss the paper very, very important. Thank you again for having me.
Yeah, and I remember that when you were working with our group, you came into the Echo Lab quite often, and we really felt enriched by your collaboration and interaction. Can you tell us a little bit about your thoughts with respect to how important it is for echocardiographers to collaborate with cardiac surgeons in this type of procedure and others? What are your thoughts on that?
Well, I think that's key, but I would actually, in a way, change also the angle by saying how important it is for surgeons to understand that the collaboration with the echo team is crucial, because I've always found, also when I was in Kingston and now at St. Michael's, a very strong support from the Echo Lab. But really, the main question then becomes, what kind of information can we ask to optimize the procedures? And it really becomes critical. I think the mitral clip that historically has been more in the hands of interventional cardiologists who've been working more closely with the Echo Lab has somehow always seen this like deeper interest in understanding potential, echo findings and characteristics. For surgeons, historically, as you know, there was the position of saying the surgeon will figure it out in the OR, which is something that nowadays I don't think it's that applicable in general, especially as you move towards less invasive approaches. Imagine to just test a mitral valve problem on the flaccid heart just by injecting cannot give you the reliable information that you need. And it is actually, I have to say, as much as mitral surgery was my focus, I've learned a lot by doing clips. And then I've translated some of the analysis back in the OR. So I think it's actually a very important process.
That's great. It's wonderful for you to provide some of that background information. And before we get into the paper, Dan's going to talk to us about the paper. How do you use echo in your day-to-day practice, and especially with respect to mitral valve repair? Can you tell us a little bit about your practice and your approach to operation in these patients?
Yeah, so I think that for sure there are like a couple of steps that have become now routine. So obviously one is trying to have a very thorough 2D analysis of the valve as to make sure that we understand what are the mechanisms. I think that what we are seeing, for example, in the paper we'll discuss today, is actually a more and more common scenario in terms of having sometimes degenerative, sometimes functional, but also some like calcifications, which is making the interpretation of the mechanisms a bit more challenging. So I think that first of all, it's crucial not simply to, let's say the TEE preoperative should be mandatory, not that much to, as you know, determine the severity of the MR, but more to understand and make sure that we rule out all the different mechanisms. I found that the 3D has become a very important tool as well when you are confirming in a, in the three-dimensional fashion, also the origin and direction of the jets that can even help imagine how it is. I have to admit my repair are nowadays almost completely echo-based. So I obviously perform a surgical assessment, but I do not tackle something which may look strange. I go by what I've seen dynamically, so that's key. And as you were asking also about the transcatheter approaches, it's obviously key to understand how the valve is going to behave once you've deployed a clip. I have to say that this is maybe a very, what we are going to be discussing today, it's going to be a very challenging area since we do not know exactly how sometimes even myxomatous valve is going to behave.
That's wonderful. And I'm glad that what we do in the Echo Lab does help you perform the work that you do. So I'm going to read the background for the paper, and then I'm going to get Dan to help us go through some of the aspects of the paper. So Dr. Oguz and his colleagues write that iatrogenic mitral stenosis is a known limitation of transcatheter edge-to-edge mitral valve repair, but determinants of increased post-procedural mean diastolic gradient are not well defined. The aim of their study was to determine correlates of increased post-transcatheter edge-to-edge mitral valve repair mean gradient or aborted clip implantation due to increased mean diastolic gradient. So Dan, I'm going to let you go to your slides now. And if you're able to walk us through what they did in this paper and what their results were, that would be great.
Yeah, so thanks so much for that introduction. And let's just see here. I think we've sort of touched on this, but our paper today is really looking at the mitral clip or transcatheter edge-to-edge mitral valve repair. So this is a technique that's being increasingly used, and certainly in our Echo Lab, I've noticed over the last year, the request to have a look at a mitral valve prior to intervention has become one of the more common things we do day to day. Actually, I'd say we're doing one or two of these every week in preparation for either a mitral valve repair or a clip. And really, part of what we're trying to do is, as like Dr. Bisleri said, is help predict what's going to happen after we put the clip in. As we all know, the mitral clip is able to reduce the degree of mitral regurgitation, but that does come at the cost of reducing the mitral valve area. Certainly, you don't want to trade a severe mitral regurgitation for severe mitral stenosis. That may not help the patient in the long run. So really, we want to get a good sense beforehand, or as best we can, to try and figure out what the gradient we're going to be left with if we have a successful clip placement. So we do know that an elevated mean diastolic gradient following clip is associated with reduced post-procedural survival, increase in rehospitalization, and other adverse outcomes. However, despite there being some guidance out there as to which valves to do it on and which valves not to do it on, there's really not much data in terms of anatomic and procedural risk factors for an increased gradient post-procedure. And really, no one's really tried to quantify or evaluate the impact of mitral annular calcification prior to this study. Essentially for this study, they did take 118 consecutive patients. This was done out of the Mayo Clinic. And they did a few different investigations. So they did a 3D full volume and zoom acquisitions during the intraprocedural TEE. They looked at 3D planimetry performed at that time to assess the mitral valve area. And then they went on and did something else as well. They looked at the degree of mitral annular calcification, which was quantified by 3D. I must say in our lab, we regularly do the 3D planimetry for the mitral valve area, but really I haven't seen us try and quantify mitral annular calcification with a 3D technique anyway, certainly on TEE. So they looked at a couple different measurements, including percent circumference, and then annular calcification leaflet infiltration length. And I'll show you some pictures as to what that means. And essentially the main outcome they were interested in was having a high post-procedural gradient, so a gradient over 5 millimeters of mercury, or having to abandon the procedure and remove the clip due to an intolerably high gradient. So in terms of the mitral annular calcification measurements, something I wasn't super familiar with before this paper. So what they've done is essentially here. So in picture A, that they really were looking at the annulus and looking at the degree of calcification around the annulus. So one thing they did report was the percentage of the annulus that it encompasses. And then the second thing that they reported was the largest dimension along that, as you can see by the green line there. The more interesting measurement for me anyway was the length of extension along that posterior leaflet, as evidenced in B. So this leaflet infiltration length is essentially MAC extending into the posterior leaflet, which, as you might imagine, would decrease your overall orifice area and might be a problem after a clip is placed in terms of your effective orifice area at the end of the procedure. And then finally, they also gave us a percentage of that infiltrated MAC to the overall length of the posterior leaflet. And the overall length of the posterior leaflet is shown in C there. So this was a new measurement for me anyway, and it's something that I think was relatively easy to do for most people with our 3D techniques. In terms of the baseline characteristics, so again, these were just patients followed over time. In total, there were 112 included in the study. And really, they do look like your typical patients that are getting clips. These are predominantly male, about 80 years old, with a host of comorbidities that you can see there. Relatively high risk in terms of STS score. A number of them have had prior cardiac surgery. A number of them, the majority of these patients actually had primary MR as opposed to secondary MR. And in terms of the actual procedure itself, there were a number of patients that had more than one clip. So I think this is a pretty good representation of what most labs would be doing in terms of their clips. But Dr. Bisleri could potentially talk a little more to that than me. Not a lot in difference between those with a high gradient and those with a low gradient after surgery in terms of their underlying comorbidities. When you look at the baseline echocardiographic characteristics, again, these are patients that I think we're quite familiar with, that you'd often see going for MitraClip. Here they do list the differences between patients with low gradients following clip and those with quite high gradients, so gradients above more than 5 millimeters of mercury. And you see here patients that tended to have a lower EF tended to have a lower gradient as well. But aside from that, there wasn't a whole lot of difference between the two groups here. The one thing I would note here is all of these patients had either grade 4 severe or grade 3 moderate to severe mitral regurgitation. So these were all people, again, that you would expect to be seeing in the lab for a clip. This is where it gets interesting, at least from my perspective, in terms of what predicted a high gradient post-procedurally. So as you can see here, they did look at a number of things. First of all, resting elevated mean gradient. So for them, they define that as a mean gradient over 4. So if you have a high resting mean gradient, certainly after the clip, you are at risk of still having a high mean gradient. That's sort of intuitive. But I was interested to see that only 7 of the 112 patients actually had a resting mean gradient over 4. The next thing they looked at was resting mitral valve area. So again, this was done by 3D planimetry, which I think most labs would be doing at this point. And there was a smattering of patients that had a mean gradient or a mitral valve area less than 4 before we started the procedure. So these patients actually probably would have been excluded from a number of the trials with a mitral valve area that small. And as you might expect, patients with a small mitral valve area to begin with tended to be more likely to have an elevated gradient after the clip was inserted, though not 100% so, but we'll show you some more data on that in a moment. And then finally, looking at the degree of annular calcification. So certainly the more annular calcification you have, the more likely you were to have an elevated gradient. And really what the authors honed in on in this particular paper was looking at an infiltration length of greater than 6 millimeters. So remember, we just showed you how to measure that. So that's the MAC encroaching on the posterior leaflet and extending into that annulus. And that if that length is more than 6 millimeters, the authors found that there was a significantly higher risk of developing a high gradient post-procedurally. So with all that said, in general, smaller valve area begets small valve area, higher mean gradient begets high gradient post, and then finally, the more MAC you have, the higher gradient you are to have afterwards. In terms of looking at this graphically, you can see here that with a baseline valve area, if you have a mean gradient, or sorry, keep talking over myself here. If you have a valve area less than 4, you were more likely to have an elevated gradient afterwards. With figure B, if that leaflet length is more than 6 millimeters, again, you are expected to have a higher gradient after the fact. And here it's interesting, they did break them down in terms of all patients and then baseline mean gradients. Remember here that there aren't many patients that started with a mean gradient greater than 4, so these are quite small numbers that we're hashing out here. And then finally, looking at the mean gradient according to baseline characteristics here, looking at difference between female and male. That didn't hold true when they did their post hoc analysis. There was, again, a significant difference between having a infiltration length more than 6 millimeters. There was a significant difference, again, between mitral valve area less than 4 and more than 4, and as well as mean gradient. So again, a few different figures that all kind of say the same thing at the end of the day. This, I thought, was sort of the highlight of the paper and really sums it up for us and sort of gives us a flow sheet to follow for these patients. So when we're looking at a patient beforehand and we're trying to assess the risk of the mean gradient being elevated after the procedure, the authors proposed this flow sheet, which I think really sums up what I've been trying to say over the last few minutes here, in that if you have a very small mitral valve area, so if your baseline mitral valve area is less than 4 centimeters squared, you are at quite a high risk of developing a high mean gradient post-procedurally, or having to abandon the procedure because of a high gradient. Conversely, if your mitral valve area is more than 6 centimeters squared, you really have a low risk, regardless of any other factors that are going on. So if you've got a big enough mitral valve area to start with, you're probably going to be fine, regardless of how much MAC or other things is going on. It's these sort of gray zone patients, the patients with the mitral valve areas of 4.5, of 5 centimeters squared, that may need a little more thought beforehand. So here, if they have a mitral valve area between 4 and 6, and that infiltration length of more than 6 millimeters beforehand, or a mean gradient of more than 4 millimeters of mercury beforehand. These patients, if they have either of those, seem to be at moderate risk of having an elevated gradient and may warrant some special consideration before you decide to proceed. Whereas if you're in this middle ground and you have neither of those, you're at a relatively low risk, so really no different than the patients with a valve area of more than 6. So I think this is a very useful flow sheet. I'd be interested to hear Dr. Bisleri's thoughts on it. But I think this is something we should be thinking about before selecting our patients for this procedure. And I think that's about all I have.
That's wonderful, Dan. I really appreciate that. So a couple of questions. Did the authors talk about some of the inter-observer variability or how they approach that for their echocardiographic parameters in terms of the calcification length or the mitral valve area?
Yeah, so they did actually, and it was actually quite impressive. They did both intra and inter-observer variability, and the numbers they got, especially for the measurements of the mitral annular calcification, were quite high, upwards of 90% correlation, or 0.9. So that was actually really well done, and really showed that between people and over time that these results can be reproducible.
That's great. So before I get Dr. Bisleri to give his comments, I was wondering, Dr. Bisleri, if you can tell us the extent of the problem. So, we're trying to avoid the risk of a high mean gradient or aborted clip implantation. So how often does that happen? And what is the extent of this problem that we're trying to solve from a big picture point of view?
Well, first of all, Dan, you provided an excellent overview, and I think Hammer, you're exactly, hitting the nail on the head regarding the selection process. I have to say that there are some differences compared. I don't know if you want me for maybe better understanding from the audience. I can share the screen because I have the presentation as well, and I can.
Sure. Yes, definitely.
Maybe that could help. So Dan, you should stop screen.
Oh, sure. Stop share. Sorry, all yours.
So overall, I would say that the landscape has significantly changed compared to the initial experience with CLIP, where maybe certain criteria were very strict criteria were utilized. Nowadays, there is a wider application of CLIPs. And I have to say, I'm fortunate that I joined this great team at St. Michael's. They have an extremely vast experience, if not the largest in Canada, where obviously clips are used also in cases that you alluded to that could be considered as contraindication. I think that what all of these discussion speaks to is that right now we have only one tool to treat the valve in terms of repair, mitral valve repair, the mitral valve in a percutaneous approach. But as you know, we are hoping to get additional tools down the line. There has been initially also the use of a ring. It was called a Cardioband. Has been now under reassessment due to some potential issues during implantation. But the idea is also that you're not simply treating the leaflets, you may treat the annulus. Number two, there have been already discussions, at least from the development standpoint, in order to have similar to what we do in surgery when we implant neocord, so the artificial cords to stabilize leaflets, to do that in a percutaneous fashion. And I personally believe that as a surgeon, as a big user of cords, these cases we're discussing today, so patients with potential calcified involvement of the leaflets or maybe borderline area, could potentially be good candidates for other approaches as soon as they become available. So it is a problem because I think that the clip is an excellent tool. The first thing I want to comment here, when there was a discussion about the mitral valve area, number one, as to clarify, the area for the mitral clip should not be measured at the annular level, but it should be measured at the leaflet tips. And this is important to clarify because otherwise it's useless to have the one at the annular level, but it should actually be measured using potentially the NPR, so that you make sure that you're not over or underestimating the actual value of the area. As you mentioned, 4 is usually considered safe. I have to say that it makes sense. It's pretty intuitive to see that you should have 6 if you have some calcifications, because the leaflets are going to be more rigid, so more likely to create a gradient. So it gives you more room. I have to say that I found myself very interesting, because this kind of definition of the amount in terms of like percentage, as well as the extent in the leaflet, is still fairly new. And I believe that this is going to be extremely important moving forward, as to find a way to standardize how much we're quantifying, so that hopefully we can come up with a sort of range or scale that can allow us to really be a bit more precise. Because
a more automated approach.
Exactly, because I don't know, maybe Dan can comment on that, but I didn't get the impression. There was a slide that was showing the 25% or so involvement, but you didn't really get the extent. For example, when you're talking about transcatheter approaches and you have MAC for you may have heard sometimes the TAVI in MAC, so transcatheter valve replacement in MAC, you need to have a certain extent. And we roughly know that at least 2/3 must be calcified. You need to have a horseshoe or more. So I didn't really understand from this one what could be the cutoff, but not because obviously the article was not precise, because that's new evidence. So I think that's the direction where we should try to understand. Maybe is it like one spot, or if it's more diffuse, right? Because the scenarios could be one area where the chunk of calcium is going, I don't know, P1 towards P2, or maybe it's the entirety of the posterior leaflet being involved, but not so much into the leaflet height per se. So these are maybe the nuances that could really affect, because obviously depending on where your segment is affected, if the chunk of calcium is on the opposite scallop than where you're treating, maybe it may not necessarily affect the gradient. So these are other important nuances. And one thing that I wanted to stress about this paper that definitely highlights how critical this can become is in this table, you see the number, the type of clips here at the bottom. So it's quite surprising that, so for the audience who's not familiar, we now have different models of mitral clip, from smaller sizes to larger sizes. And what you can see here, the NT is actually the smaller side, and the XT is the larger side. So clearly, if you have a smaller area, you tend to use a smaller clip. But sometimes if you have a good length of the leaflet, you tend to go for a larger clip, because a larger clip potentially can have a better grasp. You don't want just a tiny grasp on the leaflet. You want a good grasp on the leaflet, because that can make the clip more stable from that standpoint. But obviously, so here, despite the majority of patients received a smaller clip, the NT or the NTR, still the problem was there. So it definitely, it's a sort of at least flag about a problem that may arise. I personally, when I don't know if it was in this part where there was, the severity, obviously the flea leaflets, there was one about the gradient at rest, where as you know, sometimes the gradient can also be affected by the severity itself. If you have torrential MR, that could actually falsely lead you to a higher gradient. So I don't know how much the gradient at rest. I think that more the behavior of the valve. And again, importantly, these were primary MR in a good percentage of cases. Again, in primary MR, you may have redundant leaflets, thick leaflets on top of that with calcifications. When you have functional, typically the leaflets are thinner. And as you know, the problem is in the ventricle and not in the leaflet itself. So and maybe it's also less likely to experience calcifications in presence of functional forms. So it is definitely a key question to better understand, because unfortunately sometimes we have mixed mechanisms leading to the problem, and pinpointing where the problem is and how this is affecting with this kind of assessments is going to be key to provide the best care.
Thank you, Dr. Bisleri. I think those are some great points showing the power of the ultrasound to better select and hopefully lead to better outcomes in these patients. Thank you so much for that. I think we've had a great discussion about the paper, and I really appreciate your input. We're not going to go into all of the details of the paper because I'm hoping that our audience members will download the paper and read that for themselves. And so the idea was to introduce this paper and whet everyone's appetite. And I'm really grateful, Dr. Bisleri, for you joining us and providing the input of a proceduralist. We certainly hope that once we have new papers in the future along the same area, I think it's an interesting area of further literature, further studying, and further publications that you can join us again in the future. So thank you, everyone. As you can see that ECHO has a great opportunity to help better select patients with respect to transcatheter mitral valve repair and hopefully lead to better outcomes. Thank you for joining me on episode 2 of the Journal of the American Society of Echo podcast. This article is by Oguz and his colleagues and is available in the most recent June 2021 issue of the journal, volume 34, number 6. Please join me next week for our weekly series where we will be talking about another use of echocardiography for improving patient outcomes. Thanks, everyone. Thanks, Dr. Belliveau. Thanks, Dr. Bisleri.
Thank you very much.